Next, we are going to discuss on various types of thyroidectomy, various steps in thyroid surgery, and what are the complications and what are the recent advances in thyroid. Just a small topic, but it is expected MCQ topic. So let us discuss about this topic now. So let us start from the various thyroidectomy steps. Thyroidectomy steps. So before going to thyroidectomy steps, let us understand what are the types of thyroidectomies. So please remember, thyroidectomy types are removing one isthmus with one lobe is known as lobectomy, also known as hemithyroidectomy. The old name for lobectomy is hemithyroidectomy. So this is commonly done surgery. So okay. So please don't forget the surgery. What we do commonly for single nodule on one side is hemithyroidectomy, removing one lobe with isthmus. Removing both lobes. Both lobes are removed, but I have left some tissue on both sides. Around 8 gram on right side, around 8 gram on left side. This is known as what thyroidectomy? 8 gram in the tracheoesophageal left side, 8 gram in the right side. This is known as subtotal thyroidectomy. Subtotal thyroidectomy. Subtotal type of thyroidectomy. And another surgery is in which we remove the thyroid gland, leaving 2 to 4 gram of tissue. 2 to 4 gram of tissue in only one side. 2 to 4 gram of tissue only one side is known as near total thyroidectomy, also known as Hartley-Dunhill procedure. Hartley-Dunhill procedure, in which 2 to 4 gram of tissue left on one side. Removing everything, not leaving back anything, is known as total thyroidectomy. So these are the 4 types of thyroidectomy surgeries we do. So lobectomy, subtotal thyroidectomy, near total thyroidectomy, total thyroidectomy. Okay, so don't confusion this. So what is that in Galian love and subtotal is? Subtotal we have to do 8 gram on both sides. We have to do 8 gram on both sides from Galian love. Okay, please don't forget these points from thyroidectomy. Thyroidectomy is one of the important topics in exam, so please don't forget these things. Okay, subtotal thyroidectomy is asked in exam. So I want you to remember these steps. So now I'm going to tell you steps in thyroid surgery. A patient has come to you for thyroid operation. You put the patient on table in a head-up position. What is this position of operating table known as? What is the name of this position of operating table I have put the patient? This is known as reverse Trendelenburg position. What is the use? By putting reverse Trendelenburg, the bleeding from the neck is less. By putting reverse Trendelenburg position, the bleeding from the neck is less. So reverse Trendelenburg position, the veins in the neck gets collapsed and there will be less bleeding when you operate on the neck surgery. Neck surgeries you will have less bleeding. Head-up position is done. And we keep a sandbag. We keep a sandbag below the neck so that the neck is extended like this. So neck extended position. So neck extended position, it looks like rose position in tonsillectomy, but in rose position we open the mouth, and here we don't open the mouth. So therefore this position is also known as neck extended position or dog barking position. Dog bark position is put. So now the patient is put in multiple positions like this, and now you put an incision along the skin crease. Skin crease incision made. So please remember, skin crease incision made. And the flap we have to raise above and below. The flap is known as subplatysmal flap. The flap is known as subplatysmal flap. You have to raise a flap above and below. The flap is known as subplatysmal flap. After raising the flaps, you will open the cervical deep fascia. Deep fascia in the neck will be opened, and strap muscles can be cut or retracted. Both can be done. Either if you want, you can cut and remove the strap muscles, or you can even retract the strap muscles. It is up to you depending upon the size of the gland. You can cut or retract the muscles. Then you reach the gland. You reach the capsule of the gland. Now once you reach the capsule of the gland, which vessel will you ligate first? First ligated vessel is what? First ligated vessel is middle thyroid vein. Okay, first ligated vessel is middle thyroid vein. After ligating middle thyroid vein, it is your choice whether to go up or down. It is up to you. But anyhow, superior or inferior, both are ligated close to the gland. Superior thyroid artery is ligated close to the gland. Inferior thyroid artery is also ligated close to the gland. So superior thyroid artery is ligated close to the gland to avoid injury to the external laryngeal nerve. Inferior thyroid artery is ligated close to the gland mainly to preserve parathyroid blood supply. Preserve parathyroid artery, parathyroid blood supply to be preserved. That is the main reason we ligate it close. Previously we were ligating it away to prevent recurrent laryngeal injury. But now we have to identify recurrent laryngeal nerve, preserve it and identify, ligate each vessel separately. Don't forget this point. So now change it to close to the vessel. So now I am doing the surgery. Gland is coming out. The gland is coming out. I am removing the gland. At that time, my assistant who is assisting with me is telling, sir, see, there is an yellow tissue in my hand, or there is an yellow tissue in the thyroid gland. What will I do? It can be a lymph node, it can be a fat, it can be a parathyroid gland. Anything it can be anything. So if it is a lymph node or fat, nothing to worry. But if it is a parathyroid gland, patient will end up in hypocalcemia. So immediately you ask your staff nurse to give us a cup of normal saline. Now ask a normal saline and take this and put it in this normal saline. If it is floating, it is, what is it? If it is floating, what is it? If it is floating like this, it is fat or lymph node. If it is sinking down, it is parathyroid gland. That is MCQ here. Parathyroid sinks. This test is known as saline float test. This test is known as saline float test. Saline float test. Please don't forget this point. It is known as saline float test. So if it is now a parathyroid and surgery is going on, I will keep it immediately in the sternocleidomastoid muscle packet itself. If surgery is going on, I will keep it in the sternocleidomastoid muscle packet here. If surgery is completed, patient shifted to the ward. Patient is there in the ward. Now I will go to the ward, silently put an incision on the non-dominant brachioradialis. Non-dominant brachioradialis muscle I will implant. If surgery is done and patient shifted to ward. If surgery is going on, we can keep it in the sternocleidomastoid muscle. Shifted to the ward in the non-dominant hand brachioradialis, I will keep it. So don't get confused with this. Because if surgery is still going on, easy, I can keep it in the sternocleidomastoid. Why should I keep it in the brachioradialis? If patient shifted to the ward, I will keep it in the brachioradialis. So this is one important point I want you to remember. Now surgery is getting completed. At the end of surgery, the latest concept is before closing the wound. Nowadays surgeons are keeping a drain. For what purpose we are keeping a drain? To look for bleeding. 10 years back, we don't keep a drain. But nowadays we are keeping a drain to look for bleeding. And this drain will be retained for 24 hours and remove it after 24 hours. So when will you remove the drain? You remove the drain at 24 hours. Please don't forget. So the drain kept in the thyroid site is removed after 24 hours. So this is a very important point I want you to remember. So now surgery is completed, drain is kept. What are the post-operative problems? Post-operative complications of this operation. Surgery is completed, patient shifted to what? So post-operative complication. The moment you extubate, you will see one complication. What is it? The moment you extubate, you can see a stridor. The moment you are extubating and the patient develops stridor means what is the reason? Bilateral recurrent laryngeal nerve is injured or having neuropraxia, something. It is either injured or neuropraxia is present. What should I do immediately? So please remember this is a protocol in a stridor patient. This is typical PG level topic. So when I'm extubating, patient is having stridor and I'm putting a scope and seeing there is bilateral focal cord paralysis, they are going for cadaveric position. I will immediately, don't do tracheostomy, I won't do tracheostomy immediately. I will immediately do re-intubation. I will do re-intubation and I will shift the patient with the tube inside, with the cuffed endotracheal tube inside. I will shift the patient. Cuffed endotracheal tube, I will shift the patient to the ward. I will wait for 48 to 72 hours. If it is only a neuropraxia, just with the steroids and anti-inflammatory, the neuropraxia will resolve and the vocal cords will start functioning. But if it is bilateral nerve injury, no doubt what will happen? There will be again stridor. So with the help of ENT surgeons ready in the theatre, remove the tube. If there is again stridor, immediately plan for tracheostomy at that time only. So many of the students are thinking if there is a stridor in a post-thyroidectomy patient, immediately we do tracheostomy. That is totally wrong. We don't do tracheostomy immediately. We wait for 48 to 72 hours. Sometimes it will be only a neuropraxia, not a real nerve injury. Very important point I want you to tell. So therefore tracheostomy is done then only. And those patients who are having permanent damage, permanent bilateral recurrent laryngeal nerve injury patients will be shifted for lateralization of cord. Lateralization of cord. Arytenoidectomy. You would have read these things in ENT. Arytenoidectomy and lateralization of cord are various types of surgeries done for cadaveric vocal cords so that the patient can breathe without tracheostomy in future. So this is one complication I want you to remember. Okay. So the most life-threatening complication in the post-operative, life-threatening complication. In those days, this was a very common question. Now it is not being asked. So life-threatening complication in the post-operative period. You are a CRRI. You are going to ward evening rounds. Evening rounds. You are going to the ward. At that time, you are seeing a patient with a huge hematoma in the neck. So what you should do immediately? Bedside, remove the sutures. Bedside, remove the skin sutures and neck sutures. Remove skin sutures. Immediately remove the skin sutures in the bedside and call the surgeon, shift the patient to OT because it is usually due to slipped superior thyroid artery which is causing that hematoma. So this hematoma concept is no more. Why I'm telling this hematoma concept will not be asked in exams? I'm telling this because we are keeping drain nowadays. If an examiner is asking, what will you do if your house is going for evening rounds and there is a hematoma? If an examiner is asking you, that question means he is not doing thyroid surgery. That is the point you must know about the examiner. It tests the standard of the examiner rather than the standard of your student. So there is no such complication hereafter because we are keeping a drain. Since we are keeping a drain, the bleeding will come in the drain. Therefore, we will shift the patient to catheter, seeing the bleeding. So previously, we were seeing many patients with hematoma, the trachea getting compressed, and it was very much stressful for both surgeons as well as for the patient. So we started keeping drain for 24 hours. After 24 hours, superior artery will not slip. Therefore, nothing to do. So 24 hours, keep your drain, simple issues. And what are the other complications? I have discussed about nerve injuries already. So nerve injuries, I have already discussed. So unilateral recurrent laryngeal nerve injury, hoarseness. Bilateral recurrent laryngeal nerve, stridor. External laryngeal nerve injury is the most common nerve injury. Please don't forget, most common external laryngeal nerve, that is huskiness of voice. If I shout, my timbre is lost. Timbre lost. Huskiness of voice or loss of timbre of voice. If I start shouting, my voice becomes husky. Internal laryngeal nerve injury causes paroxysmal nocturnal cough or aspiration is seen. So this is what I have already discussed in the beginning of the topic itself, nerve injuries and related complications. So what are the other complications you can see? So other interesting complications are laryngomalacia. What is it? Laryngomalacia. So after you remove such a huge thyroid gland, if you remove huge thyroid gland, suddenly the trachea will collapse and the larynx will collapse and the patient will develop respiratory distress. That is known as laryngomalacia. It is one complication. So thyroid storm can happen if you are operating a toxicosis patients. Toxicosis patients, if you are operating, patients may develop thyroid storm. And for final MBBS students, there will be a repeated question: what are the causes of respiratory dyspnea in the post-operative period after thyroidectomy operation? So this is a repeat question for final years in clinical viva. Respiratory dyspnea is due to hematoma of a slipped artery compressing, bilateral recurrent laryngeal nerve injury, vocal cord edema due to intubation, the patient developed vocal cord edema, laryngomalacia. What are the causes of respiratory distress? Laryngomalacia is also known as tracheomalacia. Tracheomalacia or laryngomalacia, the larynx or trachea suddenly collapses and laryngismus stridulus. What is this? Laryngismus stridulus due to? Laryngismus stridulus is due to hypocalcemia. It is due to hypocalcemia. I'm going to discuss about it separately. So please don't forget laryngomalacia or hypocalcemia is another complication. So now I'm going to discuss the last important complication of this topic is on hypocalcemia. Hypocalcemia is a very important complication I want you to know in this topic. So this hypocalcemia usually happens on 2 to 5 days post-operative period. It is mainly due to what reason? It is mainly due to loss of blood supply to parathyroid glands. It is mainly due to loss of blood supply to parathyroid gland and not due to removal of 4 glands. Please remember, the main etiology is due to loss of blood supply to parathyroid gland. So no surgeon is such a bad surgeon to remove all the 4 parathyroid glands. So such etiology is very less. So loss of blood supply to parathyroid gland is very important. Loss of blood supply to the parathyroid gland is very important. That is the main reason for hypocalcemia. So this can manifest in different ways. So what are the methods it may manifest? It can manifest as subclinically. It can manifest subclinically, or it can manifest as overt. Subclinical hypocalcemia is diagnosed by certain signs. The house surgeon is going and measuring the BP. At that time, the hand is going for this spasm. This is known as what sign? Carpal spasm. This sign is Troucheau sign. On raising the BP cuff, the patient goes for Troucheau sign, carpal spasm. And when you tap in front of the ear, there will be twitching in the face. That is Chaustuck sign. That is known as Chaustuck sign. So tapping in front of the ear, there is twitching, Troucheau sign or subclinical signs. When there is an overt hypocalcemia, patient will be lying like this. What is it? Patient will have tetany. By the time you go and see, he will be having severe spasm. Opisthotonus position, he will be lying. Opisthotonus. Tetany will be there. Laryngismus stridulus will be there. Patient will have difficulty in breathing. Laryngismus stridulus will be there. So with this overt hypocalcemia, so there are 2 presentations. It can be subclinical or overt. What I'm going to do in these cases, these type of transient cases, these type of transient subclinical cases, SWAT's advises, just give them oral calcium, nothing to worry. Oral calcium is enough. Nothing to worry, just give oral calcium. In this type of overt cases only, they are advising IV calcium gluconate. So IV calcium gluconate is advised only for severe symptoms like tetany or laryngismus stridulus. So in both the cases, you can see I'm not worried about serum calcium level. Why I'm not worried about serum calcium level? Because serum calcium has a wide level of value from 8 to 12 milligrams per deciliter. This is the normal range. So therefore, if you see a patient who had 12 milligrams pre-operatively is now hypocalcemia even if he is 8. So therefore, we cannot use or rely only on serum calcium. Serum calcium is not good reliable indicator of hypoparathyroidism. To rely on this, we have to have both pre-op value, post-op value, everything. So therefore, mostly we manage the patient based on clinical symptoms. If patients are coming to you with a transient cases, we will give oral calcium. Severe cases, we give IV calcium. Permanent hypocalcemia is a real case who has been all parathyroid removed. It is less than 10%, only all the 4 parathyroid removed. Such cases, we have to send them home with oral calcium plus vitamin D3 will be given to them on discharge. On discharge, we will send them with oral calcium and vitamin D3. Go and have it for lifetime. That is the problem with permanent hypocalcemic patients. So these are the important things you should not forget in the complications of surgery. So thyroid surgery is a developing surgery. There are so many recent trends. I want you to know in this thyroid surgery from billion now. There are so many recent trends. So what is one of the important complications we are worried in thyroid surgery is about the RLN injury. So RLN injury is what? Recurrent laryngeal nerve injury is more we are worried because if one side is injured, worseness, both sides is injured, it is wider. Therefore, we have to monitor it. Continuously, we can monitor whether there is an injury going on, or we can monitor it intermittently also. Intermittent monitoring is also available. Continuous monitoring is also available. Continuous monitoring is done by placing an electrode on the vagus nerve. These are new techniques. Electrode on vagus nerve. You keep a vagus nerve, we keep a electrode. So whenever you stretch the recurrent laryngeal nerve about to be injured, it will send a signal. Electrode on vagus nerve is used for continuous monitoring. This is MCQ, which you can get from Bailey and Now 27th edition. I'm discussing this because it is there in Bailey and Now. Certain points you may feel I'm discussing too much, but it is not totally. I'm not discussing anything too much. What is there in Bailey and Now I'm discussing? Only Bailey and Now I'm discussing, and some interesting points from Sabison and Swartz I'm putting inside. So I don't want to miss any point for a PG aspirant. I don't want to miss any point when those who are seeing this app should not miss a single point. That is my important thing I have during taking classes. So continuous monitoring is by keeping an electrode on vagus nerve. This can be asked as an MCQ. Intermittent can be monitored by keeping an electrode in the these are the vocal cords. By keep an electrode in the vocal cord like this. When there is an injury of recurrent laryngeal nerve, we will go for cadaveric position to send a signal. Electrode on vocal cords. So vocal cords, we will keep a intermittent signal. Continuous signal on vagus nerve. So continuous is by monitoring the vagus nerve, and ET tube, where we keep it in the vocal cord means the vocal cord at the level of ET tube. At ET tube, we keep a electrode that will send a signal if there is a injury. But point is, intermittent will find out only injury, it can find out. But continuous can prevent injury. So prevent injury is by continuous monitoring, and injury is detected by intermittent monitoring. This is the two things I want you to remember. So the question which can come in exam is for continuous monitoring of recurrent laryngeal nerve, where will keep the electrode in vagus nerve? For intermittent monitoring, where will keep the electrode? I will keep in the ET tube near the vocal cords. Continuous monitoring will prevent the injury, so it is better to have a continuous monitoring during surgery. But practically none of us is doing this, only for MCQ. Okay. And now there are minimally invasive methods. Minimally invasive methods are there. Nobody's now in Western countries, nobody's putting a neck incision because it is cosmetically ugly. So what are the approaches they are going? Like laparoscopy, they are going through axilla, through the fascia, deep to the fascia they are going. Axillary approach is commonly done. They go through submammary, below the breast they go inside, submammary. They go through submammary. So many approaches are available, minimally invasive method, and robotic method is also available. So minimally invasive thyroidectomy is upcoming operation available now. Okay. So these are some of the important points. Let me show you the images from this chapter. I want you to know these images. Thyroidectomy surgery and steps. So please don't forget subtotal thyroidectomy 8 gram left on both sides. This is subtotal thyroidectomy 8 gram left on both sides. So done till it is only one side 2 to 4 gram left. Okay, 2 to 4 gram left on one side. This is essential step. You can see we have put a skin-free incision and the gland is getting removed. So the recent advances, please don't forget intermittent nerve monitor helps to identify the damaged nerve. That's all. We can identify the damaged nerve. Whereas the continuous nerve monitor helps to identify the threat by excessive traction. It can prevent the injury. Okay. So this is a robotic or transaxillary. We can go like this. So the approaches can be axillary approach, anterior chest approach, breast approach, or the various approaches to reach the thyroid. So CO2 is insufflated to a pressure of 4 millimeters mercury to create surgery for space for surgery, and we can remove the gland through the axilla. This is the method of removing. So this is a picture showing you hematoma getting released in the bedside itself. If there is a huge hematoma, you have to release in the bedside itself. You can see this old patient. That is why patient is not having a drain. Nowadays, you always keep a drain. Even Bailey says a drain is to be kept. Okay. So this is a typical Tausche sign, hypocalcemia, Tausche sign. Please don't forget Tausche sign. So that completes the important topic in thyroid. So thyroid is one of the important chapters for final years as well as for PG aspirants, as well as for super specialty aspirants. I have taken thyroid for around 3 hours. I want you to focus every point which I have told you and read the workbook thoroughly in thyroid. Okay. So thank you.